molecular classification of the endometrial carcinoma was developed by the Cancer Genome Atlas in the year 2013. For that, we had a traditional dualistic model, which was also called as Bochman model, that divided the endometrial carcinoma into two categories, type 1 and type 2. Type 1 and type 2. The dualistic Bochman classification had the estrogen-dependent carcinomas under the type 1 categories, which was associated with obesity and which was preceded by endometrial hyperplasia. It usually had the categories with the well-differentiated type of carcinomas, and the commonly affected genes were PTEN, PIK3CA, KRAS, FGFR2, cadherin beta-1, MSI, and ARIDA1. Type 1 had good prognosis. Non-endometrioid endometrial carcinoma type 2, which is comprised of 20 to 30% in totality, was seen commonly in the older women, thinner women. Unlike the type 1, it was associated with atrophied endometrium, and the serous endometrial intraepithelial neoplasia had poor differentiation, mainly grade 3, comprised of serous category, clear cell, and carcinosarcomas. It had the genes commonly affected were P53, HER2, and CDH, and obviously it had poorer prognosis. Require molecular classification because the molecular classification was more precise, had more predictive ability, and was more diagnostically accurate. The traditional method, the dualistic method, was based upon the histomorphological parameters and was very much dependent on inter-observer variations. So we see a lot of inter-observer variations in case of the traditional method. That is why, again, molecular classification is well sought after. The TCGA 2000 has categorized the endometrial carcinoma into 4 categories. The first one is the pole mutated group. The second one is the microsatellite instability. The third group is copy number low, and the fourth one is the copy number high. Now, before we move to the molecular classification, let us recall the FIGO grading system. The FIGO grading system has divided the endometrial carcinoma into 3 categories, the grade 1, grade 2, and grade 3, depending upon the percentage of the solid growth, and this area of the solid growth has to be non-squamous. We do not include the area of squamous metaplasia in this grading criteria. So grade 1 is when you get to see the solid growth pattern, which is less than 5%. If it gets more than 5%, but lesser than 51% of non-squamous solid growth, we call it grade 2. And then we have the grade 3, which is in the case if the non-squamous solid growth pattern is more than 50%. So FIGO grade system is about the solid growth pattern. The solid growth pattern areas lesser than 5%, 6 to 50%, and more than 50%. So did anything change the FIGO grading system? Yes. If we have nuclear atypia of type 3, that is with the highest pleomorphism of nuclear atypia, grade 3, in that case, if we have grade 1, the grade 1 becomes grade 2. We add 1 grade. Similarly, if we have the nuclear atypia of grade 3, that is highest amount of pleomorphism. Then in case of grade 2 it would be grade 3. Now let us have a quick look on figure grade 1 and figure grade 2 and figure grade 3. Now figure grade 1 has a lot of glands, and we see very less amount of the solid non-squamous pattern. Whereas if we look at this figure grade 3, we see that there's considerably higher amount of non-squamous solid area that comprises more than 50% of the area. So anything that comes in between figure grade 1 and figure grade 3, that is more than 5% of non-squamous solid growth pattern, but lesser than 50% of the non-squamous solid growth pattern will be figure grade 2. The pole mutation or the ultra-mutated group has high somatic mutation frequencies. However, the copy number is stable, that is, the chromosome number is not altered. This group, although comprises mainly of the grade 3 endometrial carcinoma, but this one has best prognosis because this group, the pole mutated group, is highly responsive to immunotherapy and has a development of lot of immunogenic potential. The pole mutation group is the only group which cannot be diagnosed using ISC. So the only method by which pole mutation can be diagnosed is next generation sequencing or Sanger sequencing that identifies areas like P2H6R and V411L. The role of pole gene is to develop DNA polymerase epsilon. The function of DNA polymerase epsilon is to synthesize DNA of the leading strand, and it also helps in proofreading, that is, repair of DNA. So if the DNA polymerase epsilon gene does not work well, that means the function of repairing would be deprived. Now, as there is defect in the exonuclease domain of the pole gene, so that results in defective DNA proofreading or the repairing of the DNA. That results in a very ultramutational state, which results in high tumor mutational burden, that is more than 100 mutations per megabase. Now that state is going to result in high neoantigen state. Now this high neoantigen state has a very high immunogenic potential that is going to result in production of a lot of lymphocytes, and also results in elevated PD1, PDL1 expression. Now, because there is increase in tumor lymphocytes and PD1, PDL1 expression, these tumors, the pole category tumors, are highly responsive to the immunotherapy and shows a very good prognosis. The microsatellites are the small repetitive DNA sequences of 2 to 10 nucleotides. Now these microsatellites, they need the mismatch repair genes, which can be MLH1, PMS2, MSH2 and MSH6. Now these mismatch repair genes, they repair the microsatellites areas. Now in case of the defective mismatch repair genes, that means MLH1, PMS2, MSH2, and MSH6, the damage of the microsatellite areas cannot be repaired. Now, if that damage of the microsatellite area cannot be repaired, then we call that condition as microsatellite unstable. The microsatellite instability is also called as hypermutated. This is not called ultramutated, unlike the pole gene mutation, because ultramutation means more than 100 mutation per megabase, but this is more than 10 but lesser than 100 mutations per megabase. So we do not call it ultramutated, but we call it hypermutated. But even in this case, the copy number or the chromosome number remains stable. The microsatellite unstable group have very characteristic features, like they have higher grade, like grade 3, just like the pole mutation could have deeper myometrial invasion, the microcystic elongated and fragmented pattern of invasion. And in case of diagnosis of microsatellite instability, we should also look for Lynch syndrome, because Lynch syndrome is highly associated with the microsatellite unstable group. This group does not have as good prognosis as the pole ultramutated type, but still we call this group to have intermediate prognosis. The diagnosis is either by ISC. In that case, we look for the mismatch repair protein, or via the polymerase chain reaction assay, in which case we look for microsatellite instability. The mismatch repair protein IC expression can be seen in the forms of MLH1 PMS2 loss, or can be seen in the forms of MSH2 and MSH6 loss, or it can come as MSH6 loss or PMS2 loss. Now, this is a very simplified version for MSI testing for Lynch syndrome diagnosis. How do we go about it? Either it is Lynch syndrome, that is hereditary, or is it sporadic? So we go for the normal ISC to detect the MMR genes. If you see normal ISC, but we still have high clinical suspicion, then we go for MSI testing using PCR. And if it comes MSI high or MSI intermediate, then probably this is Lynch syndrome. If we see the normal ISC and if we see no clinical suspicion as well, then probably it's not Lynch syndrome. Now, next scenario is if we have abnormal ISC. The first scene is if either MLH1 PMS2 is missing, then we go for BRAF and check for BRAF mutation and MLH1 hypermethylation test. If the test comes out to be positive, then it is probably sporadic. But if it comes out to be negative, then now we have to do the MLH1 gene testing. If the abnormal ISC comes out to be either MSH2 or MSH6 or PMS2 is missing, then we straightly go to either of the gene germline testing. So what does that mean? So it means if the ISC is abnormal in any one of the genes, either could be MSH2, MSH6 or PMS2, that is, an indication for us to do the germline testing accordingly. Now, why this is important to follow this algorithm is because this algorithm helps us detect the Lynch syndrome. It helps us avoid the unnecessary germline testing. It helps us determine which family requires the screening, and it also helps in immunotherapy response. Now we have the third category, which is called as the copy number low, also called as no specific molecular profile. Now this one has low mutational burden, less than 10 mutations per megabyte, and this one also does not have any chromosomal number alterations. This one does not show any alteration in TP53 gene, that is, it has the normal type P53 genes, which is the wild type or the normal type. So these group, the copy number low group, can show some mutations in the PI3K, the catenin signaling pathways, the PTEN, the CTNNB gene mutation. This group usually has the grade 1 and grade 2 type of endometrial carcinomas, and this one, just like the MSI unstable type of group, this one also shows intermediate prognosis. The copy number high or Serous-like type of group, although it has low mutational burden, that is less than 10 mutations per megabyte, this group shows the high copy number alteration, that is, we see here the alteration of the chromosome number. So this group shows alteration of the chromosome number. And the copy number high shows high frequency of T53 gene mutations, that is the aberrant type of P53 by immunohistochemistry. So what do we understand by aberrant type of P53? That means the P53 by ISC, it shows the all or non phenomenon, that is the mutant type of P53, that is the abnormal P53. It comprises of tumor with pores, the worst prognosis. It has grade 3 type of endometrial carcinomas and serous type of carcinomas. This picture shows the interpretation of the P53 immunohistochemistry. The picture A is of wild type, so that is the normal type, so that is, there is no abnormality. Here we see a variable proportion of the nuclear staining of the glands. Now if you look at the B or C, these are the abnormal ones, which are called as the mutant type. The mutant type can be either with overexpression of the staining or the underexpression or virtually no staining of the neoplastic cells. Here we see virtually all the nuclei are expressing the immunohistochemistry stain. So this is the all type of mutant P53 stain. And this one we see here, these are the P53 ISC staining expression. But if you look at this image shows that the P53 expression is done only by the stromal cells and not by the neoplastic cells. So that is, this is the complete absence of the P53 staining. So we call this type of mutant staining pattern of the p53 as null mutant p53 staining pattern. So in case of the mutant staining, that is abnormal expression, we can either have the all phenomenon or the p53 missense mutant, or the non-expression, which is called as p53 null mutant. In case of the null mutant expression, the stromal cells expressing the p53 stain is considered as the internal control.